of the program. Our first invited speaker is Dr. Teri Schreiner. Dr. Schreiner is an associate professor of pediatrics and neurology at the University of Colorado and director of the neuroimmunology program at Children's Hospital, Colorado. She was part of the care team that identified the first cases of acute flaccid myelitis in children in Colorado in August 2014. She's been one of the leaders in the field characterizing the clinical features and natural history of this condition and its response to treatment. Please join me in welcoming Dr. Schreiner.
Good morning. It is truly an honor to be here this morning, so I'd like to thank the members of the Science Committee for this invitation. It is an important topic, and I'm anxious to tell you about how our understanding of it has evolved over the last several years. I have no disclosures relevant to this presentation. So although AFM is not likely to be a new condition, our understanding of it has evolved in recent years. And for me, the story of AFM began in a beautiful late summer in Colorado, a picture that you see here on the left, at the Children's Hospital of Colorado. I and my colleagues were taking care of patients in the hospital during a time that there was an amazing and out of normal surge in the number of respiratory admissions to our hospital. So the respiratory admissions seen here are in red. This was over the baseline level that you see here in blue. But what we're here to discuss is the bar graph in purple. These were the patients that presented in the context of this respiratory illness with focal limb weakness. Now, we've seen focal limb weakness in our hospital before, and on the right you see a graph of the prior years leading up to this time, and you can see the baseline incidence was far lower than what we recognized in that late summer and early fall. So I'd like to take you through a case of one of the first patients to present with AFM, as it helps to illustrate the disorder and what we've come to know about it. And this is Dominic, and Dominic has generously agreed to share his story and his pictures so that we may all learn from him. He was 18 at the time. He was a healthy soccer-playing guy with no past medical history or unusual exposures. And 1 year later, you see the results of AFM on the right. We'll talk about what happened in that year. So he, like many members of his family, and as I've described, members of the community at large, was suffering an upper respiratory infection that August. He started to get better, but then developed difficulty swallowing. His voice was changing. He developed some back pain, and this led him to seek care in an emergency department and then subsequently be seen by an ENT. He was diagnosed with a low-hanging uvula and prescribed steroids. And then on the day of his presentation to us, he awoke with severe left arm weakness that was more proximal than distal, and neck weakness as well. When we saw him in the emergency department, our exam mirrored his symptoms. We saw that he had cranial nerve findings of hypophonic speech, palatal weakness, and on motor exam, he had weakness of his left upper extremity that was more proximal than distal. Importantly, he had flaccid tone, and he had neck flexor weakness. He was diffusely hyporeflexic throughout, and the rest of his neurologic exam, including mental status, was normal. So we obtained an MRI to better understand his symptoms. Some of the symptoms that we saw in exam seemed lower motor neuron, but with the cranial nerve findings as well, we wanted to better understand how to localize this. So in the central pane here, you see a longitudinally extensive lesion running really from the cervical medullary junction all the way down into the thoracic cord in the anterior part of the cord. When we look at this axially, seen here on the right, we see that the the lesion really is restricted to the gray matter of the cord. And interestingly, on the left here, you see axial sections through the brainstem showing that he had lesions in the dorsal pontine tegmentum as well as the bilateral dentate nuclei as well. This was an interesting constellation of findings. We were thinking about infectious as well as post-infectious etiologies, and we obtained a lumbar puncture. The lumbar puncture was notable for a lymphocytic pleocytosis, normal glucose and protein. We tested the CSF for various viral pathogens, which were negative. Days later, we would also learn that the oligoclonal bands and IgG index were normal. We checked serum for viral etiologies as well. We checked for aquaporin 4 antibody, given the longitudinally extensive nature of his spinal cord lesion. And other tests were also negative. What was positive was his nasal viral PCR for entero and rhino, which we subsequently speciated to be enterovirus D68. Now, our differential diagnosis of what can cause focal limb weakness is broad, but in the context of a positive enterovirus D68, we thought more seriously about whether or not this could be a non-polio enterovirus causing his symptoms. We contacted the CDC as, again, Dominic, which I'm presenting to you, was one of many patients presenting with similar features to our institution. And together we came up with a case definition that included not only age restriction of less than 21 years, but the clinical findings of focal limb weakness, the MRI findings, which I've described to you, and the time period. And then this notice went out to the health alert network throughout the country, and it wasn't long before we saw that our experience with these patients was not unique. In fact, there were many places across the country and Canada with similar patients. So what is the enterovirus D68? Well, it is a single-stranded positive sense RNA virus. It is part of the Picornaviridae family, and it has some particularly nefarious cousins. You see it circled here, but right above it we have poliovirus, well known to cause focal limb weakness, and other cousins, enterovirus D70 and 71. Now, unlike polio, enterovirus D68 is spread through respiratory secretions. So you can imagine with a population at that time experiencing an enterovirus outbreak of respiratory disease, how easily that might spread throughout a community. Now back to Dominic. So he was admitted, and unfortunately over the following days, he had worsening dysphagia, dysphonia, and left leg weakness. He required transfer to the ICU and was intubated for airway protection since he was unable to protect his airway. A trach and a G-tube were placed, and he was treated with 2 days of steroids as well as intravenous immunoglobulins, given that at this time we didn't know the nature exactly of what we were dealing with. He reached maximal weakness 10 days after the onset of his neurologic symptoms. From that point, he had a slow and incomplete recovery. He was admitted to the rehab unit for 32 days. He had his trach removed during the course of that. When he left the hospital, he was still having difficulty swallowing and was on a limited diet, and it was many months later that he was able to have the G-tube removed. Now, further data to help us understand this disorder was obtained 2 months after Dominic's presentation and then again 10 months later. And these were the electrodiagnostic findings. On motor nerve conduction studies, we saw that there was both ongoing and chronic motor neuropathy or neuronopathy, and that was seen in the decreased amplitude of the CMAPs. This did improve over time, but even 10 months later, there was still evidence of ongoing disease. And then on EMG, we saw at both time points ongoing denervation And what was particularly notable in the 10-month scan was the absence of motor unit action potentials in the biceps and triceps, portending a worsened recovery. And this is what he looked like. So 12 months after presentation, you can see profound weakness of the left shoulder girdle as well as the biceps of the triceps on that left side. And he was kind enough to share this picture from last week, which again shows really marked atrophy of that left upper extremity and shoulder. So in summary, we have an 18-year-old previously healthy young man who, in the context of this respiratory illness, developed profound left upper extremity weakness with limited recovery. Let's discuss terminology for a second. So the term acute flaccid paralysis is well known to us and encompasses a variety of different disorders known to cause weakness. It's a clinical description, and its most notorious member is the polio virus. Acute flaccid myelitis falls within that umbrella term, and it has not only clinical criteria, which you see there, but also MRI criteria. And these are the findings that I've shown you already. Now, many of us in this audience will not have seen poliovirus, and that is thanks to the success of the vaccine initiative, which started in 1955 and subsequently 61. And we can see the effect that that had on the incidence of paralytic polio in our country here, with a marked drop-off, and ultimately eradicated in 1979 from the US. But it's not the only virus known to do such things. We have very clearly established the enterovirus 71 as another pathogen that can cause this degree of weakness, as well as the MRI findings that we were currently seeing in this cohort of AFM patients. Furthermore, Hopkins syndrome, which was described in the 70s and reported as recently as 2010, was a syndrome described clinically of weakness in children following an asthma attack with absence of sensory involvement, bowel or bladder involvement, and with limited recovery. So what are the distinguishing features of AFM? Well, we see a preceding febrile illness almost as a rule. Most often that febrile illness is upper respiratory, but there have been cases of GI illness as well. This is reported a median of 7 days before the onset of neurologic symptoms, and those neurologic symptoms of weakness can be preceded by fever, again, headache, neck stiffness. We see that, unlike Dominic, most patients with AFM are school-aged. There is a slight male predominance, and they are mostly healthy, immunocompetent patients, though there have been a handful that have had immunocompromised from one disorder or another. And most notably, this seems to occur on a biennial basis. As you see from this graph here provided by the CDC, the marked pattern of occurring every late summer, early fall, recently on the even years, so 2014, 2016, and 2018, and we see that the number of cases and the states involved is increased. Clinically, like Dominic, we see asymmetric weakness. This is important because it distinguishes AFM from other things on the list that you may consider, such as Guillain-Barré. It progresses over hours to days. It affects proximal muscles more than distal, and upper extremities more than lower. The flaccid tone, of course, we keep in mind, as it's in the title, and importantly, normal sensation. If there is pain, this is usually transient at the onset, as are bowel and bladder symptoms. Rare encephalopathy is reported. From laboratory features, we see CSF pleocytosis, there may be elevated CSF protein, and importantly, the enterovirus PCR is most often found in the respiratory specimen, and that is true primarily for D68, though there are others, as I've mentioned, enterovirus 71, which may be found in other sites. The electrodiagnostic findings may not help you acutely when your patient presents, but in weeks to months after, you may see decreased complex motor action potentials, amplitudes, and normal sensory nerve conductions. The lesions seen on MRI are also distinguishing. Here I've included pictures from the California cohort, which again illustrate the longitudinally extensive nature of the spinal cord lesions and the real focus on the gray matter only. The cervical spine is more often included, represented, but the signal change may not be present at the onset, and it may evolve over time. So it may seem more diffuse in the course of acute illness, focus down specifically on the gray matter subsequently, and then may even present as radiculopathy subsequently. And over time, these lesions may resolve. Many AFM patients also have lesions in the brainstem and the dentate nuclei, as our patient Dominic had, and there are reports of supratentorial lesions as well. So when should you as a clinician suspect AFM? Well, as I've mentioned, there is a strong biennial tendency. So time of year and year matters, and we're all sort of holding our breath waiting for the fall of 2020. If you have a school-aged child with a prior febrile illness and focal limb weakness, AFM should be on your differential. And when it is, there are a multitude of tests that can and should be sent when customized for your patient. But keep in mind, the enterovirus PCR may not be positive in all sites. And we would really love for it to be positive in our favorite bodily fluid, the CSF, but unfortunately it rarely is. Really, where we detect it most is in the nasal PCR. And it matters when you swab. Within the first week, we stand a much greater chance of seeing the enterovirus D68 if it's present, a smaller chance in the second week, and then subsequently it really becomes difficult to detect the enterovirus D68. Of course, additional diagnostic information that you will pursue will be the MRI of the brain and spinal cord and the EMG. Unfortunately, there's no treatment with clear benefit, and many treatments have been tried. What we know is that IVIG may have antibodies to the enterovirus D68, which can be beneficial, we think. Intravenous steroids may or may not be helpful. It's unclear, but certainly in cases of cord edema, it should be used. Plasmapheresis has been attempted with unclear results. And fluoxetine, which has in vitro effects against the enterovirus D68, really has shown no benefit. Supportive care is the mainstay, and for chronic treatment, it's rehabilitation. But we have learned more. We now have a mouse model, thanks to Dr. Hickson and Tyler at the University of Colorado. They have been able to create a mouse in which acute flaccid weakness develops after intracerebral injection of the enterovirus strain. And what we see on the right is path data showing dying anterior horn cells and viral particles there in their mouse model. And the mouse model has confirmed for us that IVIG, when administered early, at least in a mouse, might help outcome. We've also learned that steroids, when administered to a mouse, may harm and worsen mortality. And it is confirmed that fluoxetine really has no effect. So what are the future directions? Well, we know so much already about the pathogenicity, but as we can learn more, we can develop proper prevention strategies, which may include vaccines, to protect our children against this rare but severe disorder. We can also hope to find acute treatments that are effective for the patients for whom we can't prevent the disease. And for chronic treatment, we may find that nerve transfer surgery has a place for some patients. Now, I'd like to thank you all for your attention, but I'd also like to thank Dominic, seen here with his fiancée, who has agreed to be our case study for today and to share his story. I'd like to thank the CDC for their collaboration, my home institutions of the University of Colorado and Children's Hospital Colorado, and my team members. They could not be better. They are just dedicated individuals who are working hard to make sure we understand this disease better. Thank you so much.